time to be on today. Really appreciate it. Obviously, this is this is something that hasn't happened in the U.S. in quite some time. And you'd have to go all the way back to the early 1900s when we had the 1918 pandemic that required the nation to do much of what we're doing now, which is sheltering in place and taking some of the other measures that we had to in order to keep the country safe. And it had a huge economic effect and a huge health effect and outcome because of that time period. So I think it's great that we have such an excellent roster of healthcare professionals here today to talk with us about what we can do and to help help these communities out that are suffering right now from the healthcare outcomes because of COVID-19. What we can do to make those better, and what sort of steps we need to be taken to just really keep everyone safe. One of the things that continues to worry me, and just so you have some background on my district, I mean, the district that I represent has the highest uninsured rate out of any congressional district in the entire country. And so because of that, the district is being hit hard, and districts like mine across the country that have elderly populations that tend to be low income, tend to be heavily minority, are also dealing with the effects of this. That's why I want to host this discussion so we can talk about ways that we can disseminate information to communities that are affected by this to help curb the pandemic. One recent study found that African American community is disproportionately impacted by this pandemic. The Black community makes up about 13.4% of the U.S. population, but counties with higher African American populations account for more than half of all COVID cases and about 60% of deaths in some cases. And I think that we've all seen what's happened in Detroit as just a sort of example of that. There was an article that stated that in some areas of the United States, COVID-19 is killing Latinos at up to 3 times the rate that is killing whites. And we know that this is also unacceptable. Scientists also say that there are structural factors like density of households, a certain employment and unemployment issues, discrimination, and access to healthcare, like I talked about earlier with my district being so disproportionately impacted by having such a high uninsured rate. We know that these are also factors that lead to some of the statistics that I talked about. And they are alarming, but we have to figure out how we can close these gaps that are hurting our community. And as a member of the Energy and Commerce Committee, which oversees, by the way, on energy and commerce, it oversees all of the pharmaceutical drugs, healthcare, and so all of those issues. So we're the committee that I serve on. We are literally right in the middle of everything that's happening on how we're going to deal with COVID-19. And I have made expanding healthcare a critical part of what I do on the committee, especially to minority communities like the ones that I represent. I think that expanded Medicaid is going to be a critical component to help bring down these statistics. And last year I introduced the Incentivizing Medicaid Expansion Act to extend Medicaid coverage availability in 14 states that have yet to accept Medicaid expansion under the Affordable Care Act. I did this along with Dallas, my fellow colleague, Colin Aldred, who represents the 32nd Congressional District, and Terry Sewell, that represents a district in Alabama. And just a few months ago, I had the privilege of leading a resolution condemning the Trump administration's proposed Medicaid block grant plan that would have drastically rolled back access to Medicaid for millions of low-income Americans, and it would have just made it really hard for them to access all sorts of benefits that they would have needed to stay healthy. And so I hope that the governor, because I really want to implore him to do this, is prioritize expanding Medicaid. That's what they need to be working on right now. I think that now more than ever, we need this because we have got to do everything we can to reach these communities that are uninsured and really are at the most risk right now during COVID-19. We also need to make sure that we're continuing to get accurate data about COVID-19 deaths. And I join other members of the Congressional Black Caucus calling on the data to be immediately released. The CDC consistently releases racial data reporting for COVID-19 in every state amidst rising trends in infections and mortality of minority communities with coronavirus. But obtaining the data from every state in America is critical to a targeted response to make sure that these resources are being sent to where they need to be. We know that FEMA is already using data to try and send testing and other materials to certain geographic areas and metropolitan areas around the country for that. And so we need, again, to have this racial data more focused so we can figure out how it is that we can help these communities that are suffering the most. And with that, I just want to thank all of the wonderful panelists for being here today and logging into Facebook to join me here today for this very important discussion. Now I want to hand it off to Dr. Garth Graham, who is the Vice President and Community Health Impact and CVS Health and former Deputy Assistant Secretary of the U.S. Department of Health and Human Services under both the Obama and Bush administration, where he also ran the Office of Minority Health. So Dr. Graham, I want to turn it over to you. Thank you very much for being on too. Really appreciate it.
Thank you, Congressman, and thank you for, I think, your leadership, and I think much of the caucus's leadership on elevating issues affecting minority communities across the country. So I was asked to talk about two issues which I'll touch on. One is, and you started to allude this, what can we learn from some of the prior epidemics that, especially during the Obama administration, we had tackled in terms of H1N1. And you mentioned there's a lot to even learn from a lot of the history with the 1918 pandemic. W.E.B. Du Bois, when he looked at the 1900 census data prior to the pandemic in 1918, predicted that African Americans would be disproportionately impacted from TB and pneumonia and everything else that was happening in terms of respiratory diseases. If you think about that was 100 years ago, and we're seeing the exact repeat of that here in 2020. Much of what he described back then, if you pull back a lot of the history of the pandemic back in 1918 and what the African-American scholars at the time described as both the challenges and the response are almost identical in terms of kind of what we're seeing here 100 years later. So that kind of thing is kind of scary, but there's a lot to learn when we look to the past in terms of looking to the future. I'd say there's a couple of things. And in fact, it's funny enough, Congressman, you mentioned data collection and some of the challenges. And 100 years ago, we talked about these very same challenges in terms of information, data collection, and empowering our communities. So I think if we fast forward to even the 2009 H1N1 epidemic at the time, and we saw again then a disproportionate impact in terms of what was happening with minority communities. One of the interesting things we saw then was particularly for children, we saw particular higher mortality rate amongst African American and Hispanic children, which, God, we don't see that impact of COVID-19 on the pediatric population now. But I think there's a lot to learn. So I think there's probably a couple of things to think through when we fast forward to where we are in 2020. One is, as you mentioned before, this issue about being able to track, monitor, and adequately classify data. That has been a challenge that we've faced in the country for a long time. Luckily, nowadays, we have the technologies and the capabilities to be able to track those things appropriately. So we have to think about how we utilize technology, including things like AI and other more sophisticated mechanisms to be able to track and monitor people prior to testing, in terms of testing adequately, but also in terms of contact tracing, and that's going to be particularly important. There's another thing, a couple of things I would highlight that we learned from H1N1 that I would say here. A lot of times we tell people to call their primary care physician And we mentioned that much of what needs to happen next depends on having contact with their PCP. Well, we know that African-American Hispanic populations are disproportionately don't have access to a PCP. So we have to understand some of those instructions and how they pertain in terms from a cultural perspective. Likewise, many times we tell people to socially isolate without understanding what their living conditions might be appropriately, whether that be 1 room or 2 rooms. And if you're sick and there's only 1 or 2 or 3 rooms in the household, it's hard to then be isolated from the rest of your family appropriately. Again, similar things that we've learned from prior advice given in the past, and we should think about doing here. We're at 1.3 million cases defined as a country as of today, 77,000 deaths, with some data pointing to maybe upwards of 40% of those nationally potentially being from minority communities. Similar to, again, what we saw 100 years ago and similar to what we've seen before. So as my mom said, a lot of times there's little new that's under the sun that we haven't seen before. The mistake we make often is not learning from the past in terms of thinking about the future. So a couple of things I would add here, and a lot of things that we've been doing nationally from the CVS health standpoint has been just this. In 1918, the National Medical Association and a number of other communities, a number of other leaders within African-American community rose up appropriately. And I think we need to trust in our clinicians and community representatives on the front lines in terms of messaging and be able to work with them appropriately. The other thing we do have to do, as you mentioned earlier, is utilize the technologies and the capabilities to adequately contact trace, both test and contact trace. And we've been expanding our testing from CVS Health standpoint nationally to really look at this issue of underserved and minority communities. Again, kind of learning from prior experiences before. And the other thing, the last thing is once people test positive, understanding appropriately how those instructions unfold in a culturally relevant, specific manner, and understanding how we give people kinds of instructions that are applicable to their standpoint. And from us, we really found a lot with working with the community health centers and free clinics that have been the backbone of a lot of what we'll see in terms of service to underserved communities. So that's just a snapshot of some of the things I think I've learned from prior experiences. And I think our strategy here in terms of nationally from a CVS Health standpoint.
Oh, good. Well, thank you very much. Appreciate that. And now we're going to go over to Dr. Dale.
Hey, good afternoon, everybody. Congressman, thanks for having us. Really appreciate you.
Thank you.
Yeah, really appreciate you giving us this platform to speak on this very important topic, and honored to be here. Really quick, I'm just going to share my screen because I'm the numbers guy. Okay, so let me share my screen and show you guys a few numbers I've got here. All right, we good? Everybody able to see the screen here?
Yes.
All right, so real quick, I'm just going to run through a few numbers with you guys about, what's COVID doing here in Texas, and then a little bit about what it's doing over across the country. And Congressman has already mentioned some of that data. But being Texas focused first, you see the total cases on the left side of your screen there. 36,000 cases total in Texas and about 1,000 fatalities so far. And looking over here at the counties, Harris County down in the Houston area is being hit the hardest, followed by Dallas County and Tarrant County up here close to where we're at right now. So when you start talking about, how is it really impacting us according to the race, this is a breakdown of the confirmed cases. And all this data is coming from the Texas Health and Human Services. You can go on their website and find these exact same charts. So looking at the race here, the Hispanic population is being hit the hardest, throughout the state of Texas, which, we probably we're not surprised to hear that really, followed by the white population and then the African-American population. The African-American population is still also disproportionately impacted. So, the percentage of us in Texas is a little bit lower than that, 12-13%, according to some CDC data or US Census data, I should say. But you see that we're still a little bit above what we should be in terms of impacted cases with COVID. Now, this is what I find really fascinating here, actually. So this is the chart of the fatalities. So you wouldn't necessarily expect this based on the slide I just showed you in the past, and I'll show you another slide after this to kind of tie everything together. But when you look at the fatalities within the state of Texas, the white population actually has the highest fatality rate within the state of Texas. So that's really interesting, and there are a few thoughts as to why that might be the case that I'll mention here in a second. So this graph I made earlier today just kind of put everything together to make it easier for us to see what's going on here. So if you look at the bar graphs over here to the left, so this is the percent Texas population. So you can see, in Texas, the white population and Hispanic population have the most amount of people. And then you look over here in the middle, and this is percent of COVID cases, right? So this is the percentage of the population by race and COVID cases. So again, the Hispanic population has the highest effectivity rate, and then the white population is next, followed by the black population. And then if you look at the actual percent of deaths, this is where it gets confusing again. You see the white population has a higher fatality compared to the other races. And you wonder, why is that the case? If Hispanics are being impacted more, why are whites dying more? And the reasons, I'm not quite sure, right? Nobody quite knows, but a few things to think about here. One of the reasons might be, you look at this blue graph here, right next to the white, and this blue represents unknown. So a lot of people who are dying that we don't know their race, right? So you have to say, okay, out of these unknowns, might a large percentage of those people actually be minorities, and we're just not capturing that data. So this data might not completely be accurate. The other thing to consider when we're talking about, say, the fatalities and such, is we're probably approaching the second wave of COVID here in the state of Texas, right? So we had the first wave, and we saw a lot of people being affected. And if you think about the very first cases that even came into the state of Texas, I believe one of the first ones was in Collin County, right? And you had a lot of people who were traveling, things of that sort. So there's a certain demographic type of population of people who were actually getting COVID earlier on, is one of the thoughts. The concern now is this second wave might even impact minorities at a higher rate than the first wave. And then with that impact might be more mortality, more fatalities, more deaths that come along with the second wave. I mean, just locally where I'm at, here in Dallas, I think about some of the local hospitals, and some of the hospitals that quote unquote cater to perhaps a more affluent or suburban population. They had when all this started, they were seeing COVID at equal rates, right? But now that's kind of started to die down. But the hospitals that are still seeing high rates of COVID, at least within the systems that I'm familiar with, are the hospitals that are taking care of more minority patients. So while the other hospitals cater to the more affluent populations are starting to slow down, the hospitals taking care of the indigent populations, minority populations, are still seeing relatively high numbers of COVID cases. And again, there's a chance that it might get worse here with the second wave coming. Just a little bit on some national data here. You see COVID breakdown across the country by race. And again, you look here and you say, wow, the white population has a lot of people being infected compared to other populations. But keep in mind, this particular graph is not breaking it down by Hispanic and non-Hispanic. So when you look at the next graph that actually does that, you see that the Hispanic population is actually disproportionately affected again. So that's something that we really need to keep in mind, pay attention to the Hispanic population. And as the Congressman mentioned, this is some data that's just coming out recently. This was in the Washington Post just 2 days ago, and making headlines across the country. It's been all over the news. Disproportionately Black counties, so counties that are disproportionately Black, right, are accounting for a whole lot of these COVID deaths, up to 60% of these COVID deaths across the country. Not the Black individuals, but we're talking about the counties that are disproportionately Black are accounting for approximately 60% of these deaths. And this is just a graph of that here. You can see the red dotted line are the counties that have an above average Black population compared to the all other counties here. A few thoughts, and the Congressman mentioned a few of these already at the start, but some things to keep in mind. So why are minority populations affected more? Chronic medical conditions, right? So a lot of times we're dealing with things like diabetes, hypertension, things that aren't as well controlled in our populations as we'd like them to be. And that's related to things like access to healthcare and such. A lot of us are essential workers, right? A lot of us are essential workers. We can't stay home. We gotta go to work. We live in close-knit living environments. So if we're in more crowded spaces, the risk of us spreading it to somebody else is that much higher. And then something that we always have to keep in mind is this question about distrust in leadership, which is why I really appreciate what's going on right here today. You have a congressman putting out an event like this, right? Because we need to make sure that our population, our people have that trust in our leadership. So we listen to sound advice, so we listen to guidance, and we actually do the things that our leadership is recommending. If we don't trust the leadership, we're not gonna listen. So we have to trust the leadership. A few things to keep in mind, I'll wrap it up here. So physical distancing, things that we have to keep on reminding everybody to do, of course. Get tested if you're having symptoms, of course. Stay home as much as reasonably possible. Now we understand people are cooped up, you're tired, everybody wants to get out of the house, so people are gonna leave the house. You can't stop that. But as much as reasonably possible, we should be doing that. Of course, stay home if you're sick, and Dr. Davis and I had a call this morning. We discussed this. People who are sick, some people just have to go to work. You have to get that income. So we understand that, but at the same time, it's not worth spreading this disease and the mortality, fatality risk that comes along with that. Mind your mental health, something that does not get talked about nearly enough, right? Mind your mental health. This is impacting our communities. We're seeing our friends and our family members, get infected with COVID. We're seeing them die. My brother lost a friend. I got an uncle, who's dealing with this right now. So it's impacting our community. So we have to keep our mental health in mind, our physical health, right? If you want to make sure you're healthy, you want to make sure your immune system is strong, because when it is, the chances of you being able to bounce back if you do get infected with COVID is much higher. And of course, your spiritual health. We're a spiritual population. We need to keep that in mind, definitely. So that's all I've got for you guys. I appreciate the few minutes that you allowed me to share.
Absolutely. Dr. Dale, I want to thank you too for mentioning mental health. I did a Facebook Live maybe 2-3 weeks ago on mental health because there was one young lady that here in Fort Worth that reached out to me and was like, she didn't want to shelter in place. She wanted to still socialize. And she said that not socializing was bad for her mental health. And so that inspired me to do a Facebook Live to just let people know about some of the services that are out there. In both Dallas and Tarrant County, there are MHMR services, and they usually have people there around the clock that can answer when someone just needs to talk with someone about what's going on with them. There's also 1-800 national mental health organizations where people can call in if they feel like they need to talk about this. And then always remind people that, there are apps out there now that also help you deal with stress and strain of everyday life. There is Calm is one that's very popular. There's another one called Headspace that I use that's like really popular. And so there are many apps and what have you out there that are put together by professionals that help with mental health. So I'm really glad that you mentioned that. Thank you very much for your presentation as well.
Thank you.
Also would now like to introduce Dr. Terry Major Kincaid, a doctor and also a podcast host on maternal and neonatal care to talk about how this pandemic is affecting minority mothers and pregnancies. Dr. Kincaid?
Thank you. Thank you so much for having me. Everybody can hear me okay?
Yes.
Great. So I am super excited to be on this panel, and I just want to thank you, Congressman Veasey, for doing this. I just want to hug you through the screen. This is so important for our communities, and our communities need to know that we care and that they have advocates in the community, even though they don't see us, that we're here and that we care. So I really appreciate you having this platform. So
thank you.
I'm a neonatologist and a pediatrician, and I have served as the chair for the March Your Dime Steering Committee for African American Outreach for the state of Texas for the past 10 years. And in that role, my job has primarily been to address disparities we have in preterm birth, as well as maternal morbidity. So the first thing I want to say before I address the COVID situation, that's what I keep calling it, the situation, is that we had these disparities before. We had these disparities before in Black and Brown communities. We had these disparities before. So a lot of people who are seeing the news about the COVID rates are seeing it as if this is something new. And there's an old quote that says, when America gets a cold, Black and Brown communities get pneumonia. And so this has really put a spotlight on all the inequities we have that lead to these disparities. So for women and children, pregnancy in particularly, I want to say first for Texas, our preterm birth rates were already high. We got a D on our preterm birth report card last year. It's gone up the last 2 years. We're at 11%. Black women are 38% more likely to have a preterm birth here in Texas. And being insured is not protective for all of us. Having a higher SES status is not protective for all of us. For me in particular, I became interested in this when I found out having a college degree as a Black woman is not protective for me having an adverse birth outcome. I'm actually 2 times more likely to have a poor birth outcome than a Caucasian female who has a GED. So this is something that's I've been very passionate about. For our maternal morbidity rates, in Texas, our maternal morbidity task force was convened in 2012. And we've had 2 reports since then. We're due another report this year. The maternal morbidity rates in the US are high. In Texas, they're high as well. Again, African American and Hispanic women are disproportionately affected. And I want to touch on something Dr. Dale mentioned on his slide. On the last slide, he said, you know, what are some of the reasons why these communities may be disproportionately affected? He mentioned chronic health conditions. So in that report, they mentioned hypertension, obesity, diabetes as being higher among women of color and Hispanic women. And this is true, we may see higher rates, but what I want to say to the listeners out there is we have to be careful not to blame people for the situations that they find themselves in, the situations that have been engineered for 400 years. And so when we are talking to people about, you need to take care of your diabetes, you need to eat better, you need to have fresh fruits and vegetables so you have a healthy pregnancy. Do we see the neighborhood they live in? Do we see that there's only fast food restaurants there? Do we know that they cannot afford to go to Whole Foods? I cannot afford to go to Whole Foods. So we are telling families that they need to take care of their high blood pressure, they need to take care of their diabetes, but we need to give them tools. And we have to go into the communities and think differently. Can we get farmers markets to the churches? Can we show them how to cook within their means? Can we show them how they can exercise? And so another thing I want to make sure our listeners understand as you're looking at all these rates is that today in the US, we can predict your health status by your zip code. Your zip code. You don't even have to tell me how many times you went to the doctor. I don't even have to know your conditions. You give me your zip code. I can tell you what your lifespan is and what you're likely to die of. That is a disparity. So that's the first thing I want to say about the landscape we find ourselves in with COVID. So what about our women, our moms having babies? The first thing I'm very concerned about with respect to the effect of COVID on our pregnant moms is social distancing. So we know for our Black and brown mothers that having an advocate and someone to advocate and be your voice in a very vulnerable situation is very important. Not that all moms don't need this, all moms do need this, but Black and brown women report being in situations not being heard, being dismissed, not having their complaints addressed. Serena shared that. Serena Williams had access. She is not uninsured. She was not listened. She almost died as a result of her pregnancy. So I'm very concerned about the fact that now mothers are being admitted to the hospital to have babies. Dads have to leave, partners have to leave, doulas have to leave, midwives have to leave. Most of our hospitals, you know, the moms are having to deliver just with the healthcare staff. And we want to be there for them, but it's not the same thing as having your loved one in the room to advocate for you. So one of the things I'm hoping that eventually happens is one of our hospitals in Fort Worth is now screening all moms who are pregnant from admission for COVID to see if they're negative. I'm hoping eventually that the partner can be screened too so that they can have somebody there to advocate for them, because we know that implicit bias plays a role, particularly for Black and brown moms with respect to maternal morbidity. Also, if you have a baby that comes to the ICU nursery, I mean, just imagine you have a baby, you have a poor outcome, you have a baby that has come to the ICU nursery, and now I'm saying, hey, you can only see your baby once a day, and it's either you're a dad and your 1 pound, 2 pound babies are gonna be here for 3 months, and guess what, you're not gonna be here. You guys talk about mental health. That is not good for mental health for the mom or for the baby. So we are in unprecedented times as we navigate how can we keep healthcare workers safe. Now, I'm not saying let everybody in. I myself have just got out of quarantine for 3.5 weeks. I'm pretty sure I got sick in the hospital. I'm not saying everybody can come in, but I'm saying we have to figure out a way particularly to think outside of the box. So what are some things that we know work for our Black and brown communities? Well, one thing that we know works is using non-traditional healthcare providers, having a tribe. So having a doula, having a midwife, having a foster aunt or a big sister walk alongside you. Group prenatal care. which has been pioneered by March of Dimes, where you have a tribe that follows you each month of the pregnancy, and you say, hey, is this normal? I have back pain. What are you eating? Are you exercising? Is this normal? Is this normal? What should I do? Having a tribe that you trust, because we have to accept that many of our Black and brown community members do not trust the healthcare system, and it's not without reason. So we have to do better to address the implicit bias, and we have to learn how to partner alongside our communities without blaming our communities for the situations that they find themselves in. The last thing is, Congressman Veasey, you took my last point. He started off by saying Medicaid expansion. So we need it. I mean, we have to have it. Okay, so the poverty rates in Texas, he already mentioned the poverty rates in his county are the highest in the nation. In Texas, the poverty rates are high. Now, the number of uninsured women in Texas who cannot get access to not just prenatal care, you guys, care before prenatal care. To have a healthy pregnancy, you have to be healthy before you're pregnant. So we have to help you with your hypertension, your diabetes, your obesity before you're pregnant. We can't just jump in at 3 to 4 months of pregnancy and expect that we're going to have a healthy outcome. But how can we expect people to do that if we have high rates of being uninsured? We also have maternal care deserts in Texas. So you may have insurance and may not be able to get to the provider. You may have insurance and may not have a reliable form of transportation to actually get to you guys know how hard it is to get from Plano to Fort Worth? Like it's hard. And so we need to think outside of the box. So what's a social determinant of health? It's where we live, work, play. It's where we live, work, and play. Your zip code, live, work, and play. So we have to think about the system level effects. So yes, when you're in front of me, I want you to use your social distancing. I want you to wear your mask. I want you to do hand washing. I want you to do the best you can. But while you're doing that, those of us who have the ability to affect the system outside of the direct patient care, we have to make some systemic changes to make sure that people can get what they need in the circumstances that they find themselves in. And so that's what I want to say. Fortunately, in terms of data, I was looking at Dr. Dale's slides closely. We don't have a lot of data yet with respect to pregnancy or poor outcomes in children and in babies. We actually don't even have good data yet for what we call vertical transmission, a mom who's pregnant who actually contaminated a baby, but we have some preliminary data with respect to antibodies. So we're looking at that very closely. So I'm interested to see, once we have all the data, he's mentioned a big unknown group with respect to race, but I want to know about the group that's pregnant, and I want to know about their children. I cover 10 hospitals from Dallas to Plano to Fort Worth. And in our hospitals, we've had several moms who are positive or persons of interest, but we actually haven't had any babies that have been sick, which is good. And then the last thing I want to say, I know I said last thing twice, but really this is the last thing. In terms of disparities, this is something I'm sure you probably already knew, Congressman Veasey, but I didn't know this, that in the United States, there are 2 prisons that are licensed to house mothers who are pregnant, who are close to delivery. And we have one of them. And so you guys remember just a week ago, there was an article in the paper about a mom who was COVID positive. She had been admitted to a Fort Worth hospital sick. She delivered and she remained in the hospital very sick, and she subsequently died. She actually was Native American and had come to Texas from North Dakota. So that was in the paper, and I actually was at the hospital when that mom was there, and it just reminded me of another marginalized population, our incarcerated populations. He just mentioned, Dr. Dale mentioned close quarters, and just made me think about mothers, who are incarcerated, who need health care as well. This mom actually had been seen before and dismissed and then readmitted, and she did get care, but unfortunately her infection was too severe. The baby is fine, but that's another marginalized population, and those numbers are gonna be counted, in Fort Worth. So we have to think about those moms as well. So that's what I want to say. Everybody be safe. We're thinking about you. We want to help your communities. We want everybody to have healthy babies, and hopefully everybody will be able to come and visit their babies in the nursery soon.
Yeah, Dr. Kincaid, thank you very much. And yeah, that was terrible. I was actually on the phone with the warden, the regional administrator for the prisons, the federal prison system, talking about the outbreak that they had over in Wichita at the Man's facility, and asked him to give me an update on what was going on over at Carswell too, and that was really sad. That situation. Luckily, the outbreak there at Carswell hasn't been nearly the same amount on what's going on in Wichita. So, and if you've been out to Carswell before, then you have got to meet, you have had an opportunity to meet the great and unforgettable Dr. Charles Langham, if you have been out to the Carswell Women's Facility before. So I know Dr. Langham very well. He is a neighbor.
I haven't been. I'll have to go
Have you
meet
not met
him. No.
Have you not met him? Yeah, okay. Well, he's a longtime African-American OBGYN that worked, and now he left his practice several years ago and decided, that he was going to go work at the Women's Federal Facility there. Yeah, so when you get a chance to meet him, you'll really enjoy him. He's a great guy. Next, I want to introduce Dr. Aisha Taylor. Dr. Taylor, how are you doing?
Hello, I'm good. Thank you again for bringing us all together to discuss this. It's really important. I'm an emergency medicine physician here in DFW. I've been here for about 10 years. I'm board certified and I care about the community. And I was asked to kind of talk about what this pandemic means to our community specifically, like opening back up, maybe how to access care, things like that. So I want to capitalize and piggyback on what was already said by Dr. Dale and Dr. Terry. We have a tendency in the media to make it seem like the victims are at fault, and we know that the determinants of health are based on zip code and race and a lot of things that are out of the control of the individual person that lives in the body, right? And everything from like social distancing is a privilege. If you have a big family, if you live multi-generational, you live in an apartment, you can't go out to your 3-acre farmhouse and be away from everybody, and if you are an essential worker, which a lot of brown and Black people are, then you end up traveling to higher risk areas just to do your job and keep society functioning. And then you come home and people get sick and now you did something you're not supposed to be doing, right? And so we want to kind of get away from that narrative. And I think that panels like this and good leadership helps people realize that it's not their fault. And that's so important because when people are blamed, they don't trust their leadership. They don't trust the healthcare system. They don't trust doctors. And this is very common. I mean, I work out even in East DFW in Mesquite, and people will come and say, well, I don't want a vaccine because, that's you guys injecting me with HIV, and I don't want that. And trying to get them to trust me. I've been accused of being a part of them. And I go into it with them because that's the only way that I can get their trust. So I think it's really important to address that and put it on the table because you can't get past the wall if you don't acknowledge the issues, right? So I wanted to say that again. You can't say it enough, right? And then the underlying medical conditions that make everything worse when you get sick, right? One thing that adds risk is age, but also too, like we said, we're finding that hypertension is a big risk factor, bigger than some people are saying smoking, right? So that's huge. Why is that? We're learning so much about this virus every day. It's manifesting in so many ways, skin rashes, blood clots, things. This virus is doing things that it seems like a virus like it, other coronaviruses don't do. And I think that that's important for the audience to know. And the reason why I point that out is because what can you do? Like we talked a lot about the statistics, we talked about zip codes, we talked about the color of your body and things that you can't change, but what can you do? And so as an ER doctor, what I would like to see is a little bit more knowledge given to society about when to come to the emergency room. And what does that look like? What to expect? What sort of information to bring with you? Like I tell all of my patients, listen, write down your medications, right? Write down all your medical problems. If you can, get a copy of your medical records. When you come to the ER, everybody logically thinks that the computers all talk to each other. Well, I was just here, or I was at the hospital across the street. Can't you just pull it up on the computer? That would be awesome, but we can't do that, right? And then be prepared to tell your story a couple of times. You come to triage, that person's gonna wanna know. Registration's gonna wanna know. By the time the doctor comes in, by the time I'm coming in, I get so many people, I already told all of these people, and I get it. But if you know going in that you're gonna have to tell your story a few times, it allows you to practice your story as well. Now, another thing, you want to go in and you want to have a clear communication. Why are you here, right? Like, why did you come to the ER today and not yesterday and not tomorrow? Why today? That's really important because you may have a lot of things going on, but it gets buried if you say, you know, I've been having some shortness of breath, but then my ankle hurts and then I get headaches sometimes, because then the triage nurse or whoever's listening to you just kind of puts you in a stack of not that emergent. So if you're going for a specific reason, focus on that reason. And during this time, reasons to go to the ER, I can't breathe. So don't talk about, you know, your ankle sprain from 3 years ago. No, I can't breathe, right? I'm having chest pain. I'm having stroke-like symptoms. I can't move, I can't talk. And then it's even more difficult because you can't even have anyone with you right now. And it's so hard to be a patient. So you really have to focus on the reason why you're there and communicating with the staff directly and completely, and especially your physician. So I also know that a lot of times we go to the doctor and we don't really know who's on the healthcare team. We don't know who the physician is, who the nurse is. So you want to try to identify who it is that's taking care of you. So you're my nurse, you're my doctor, okay, I'm going to x-ray. That way you follow along as much as possible so that when you have to repeat this story later, because nobody was there with you, you can give a little bit better history if you're able to. Obviously, if you're very, very sick, then all of this goes out the window. But a lot of times we see patients in the ER that are not super sick, and they can provide this information if they just knew that it was something that we'd be asking for or something that would be helpful. And then the last point I wanted to make, because there's been so many points made, but I wanted to get in there. We talk about all this disparity, and medicine is not going to fix the world, but we can make medicine better if we encourage young people to go into medicine, right? Young people of color, we diversify our physician workforce. So, and that everybody gets better care when there's diversity. Even in education, probably every field is better if you have diversity, because providers learn from each other, right? We talk to each other, we teach our colleagues, so you don't have to be, you know, Black to know Latina culture. You don't have to be, you know, Asian, because you have colleagues that can educate you, patients that can educate you because you're open to being educated. And the only way we get there and diminish healthcare disparities is to train the next generation of healthcare providers so that they're present. And you know what? There's a lot of different places for people to fit in to healthcare without being a doctor or a nurse. There's a whole long list. So I wanted to say that too, that as we encourage STEM and diversity in healthcare, we encourage young people and old people that are watching to encourage young people to pursue careers in medicine.
Nice, nice.
Dr. Taylor, thank you very much. Really appreciate that. And also you talked about the other professionals that work in healthcare. I want to salute all of the workers that a lot of times people don't know what the titles of their jobs are. I think everybody knows about RNs and doctors, but the LVNs, the people that clean up the hospitals, the techs, those other essential workers that help make the hospital run smoothly. I want to recognize them too. And oftentimes, many of those jobs are heavily Hispanic and African American that fill a lot of those positions. And a lot of times those jobs aren't as high profile, but they're still very important in making the overall mission at any health facility work and be ran well. So I want to salute them and thank you for your presentation very much. Now I would like to introduce Sharon Davis, who is DO and Chief Medical Officer, and Lenore Marquez, a good friend of mine, who is Chief Executive Officer over at Los Barrios Unidos, and talk about how COVID-19 is impacting the Hispanic community and DFW. Lenore, Dr. Davis.
We're happy to be here. Good afternoon and happy Friday, everyone. Congressman Veasey, thank you so much for hosting this Facebook event, and thank you for inviting Los Barrios Unidos. So I just want to take a couple of minutes and talk about what we do, because it speaks to everything we've been talking about, access and poor neighborhoods and trust and all those issues. Los Barrios Unidos has been around for nearly 50 years. We were started by some Mexican-American housewives and workers in West Dallas, and we've grown and grown and grown. We are now an organization that sees 93,000 visits per year, so we've got quite an impact. We are very well known in our community. We are a trusted source for healthcare. We're Joint Commission accredited, and we offer our care at deep discounts for low-income families. We do primary care, which means sick care, wellness care prevention, chronic disease management. We've got a children's dental program. We have behavioral health, so thank you, Dr. Oko, for bringing that up. That's an integral part of what we do. We have an on-site lab, on-site pharmacy, a WIC program. And actually, I appreciate Dr. Major Kincaid's comments earlier about health status and zip code. I was really moved by the Dallas County Needs Assessment that came out a few months ago, and it again, nothing new, but it's not new, but it's still shocking. You know, every time I see that stuff, it is still shocking. You know, there's this much of a 10-year disparity in life expectancy, depending on your zip code in Dallas. That's 2019. That's now. There's that kind of disparity. So that's heartbreaking. But there is hope. We serve right around between 30 and 33,000 unique patients, all ages, from newborns to people in their 80s and 90s and above. Like I said, about 93,000 healthcare visits. That's about 375 per day at all our health centers. Half are pediatric, half are geriatric. 60% of our patients are uninsured. So think about what that means in terms of healthcare access and the ease of getting care. 89% of our population are Latino, and then more than 90% are low income. So we are seeing those working Joes, working poor. We have 5 locations, all of them kind of by definitions. Community health centers are located in poor neighborhoods. That's, you know, we go to where the people are. We are opening our newest clinic in a very poor neighborhood in this coming fall. So that will be our 5th location. So we've always seen the barriers to care, and that's kind of why the reason we exist is to overcome those barriers, being language and culture. You know, language, we can teach someone to speak Spanish. We can teach someone, we can have access to a language line. That's not everything. If you go to a doctor that doesn't get you, you're gonna miss each other. I mean, it's not just language. It's much more than that. Culture, including SES background. Financial barriers to care. I think we all know what that means. That gets very complicated when you don't have health insurance. And then location. You know, if your doctor is too hard to get to, if it takes three hours on 2 buses to get to her, then that's a barrier. And you sort of think, oh, I don't think I need that physical. I can wait. I'm not in pain. Everything's fine. Also, again, several of you have talked about this as a trust issue. That's a barrier. Trust to people outside our community, mistrust of people outside our community, and mistrust of the healthcare system. Not because any one person is mean or bad or anything. It's because it's confusing. It's confusing when you speak English, have insurance, have a good job. So there's all of that creates mistrust. So we feel like Los Barrios Unidos Community Clinic does a pretty good job of reducing those barriers. However, those barriers still exist. Only today, they're more complicated because we have all those barriers. Plus we have deeper financial barriers, because now you're talking with folks who lost their job. And even though we have deeply discounted prices, they're like, I don't have $40 to see the doctor. No, we're going to see you anyway. Well, they don't want to have that conversation. It's embarrassing to say I can't afford for my care, therefore I won't get care. And then fear of the disease. I mean, this is a scary thing. We sort of struggle with this. Sometimes people aren't afraid enough, but what we're seeing is a lot of people are afraid and not leaving their homes to see the doctor. So there's some things that we're overcoming for that, but that fear has some implications, obviously, for healthcare and how we engage patients. And this is actually a really good time for Dr. Davis to speak a little bit more about that. So thank you.
All right, thank you, Lenore. And thank you, Congressman Veasey. I join everybody else. I'm just so thankful that you invited us all here. And for the rest of you guys that are on the call, it's been great to get to know you too. I really enjoyed listening to you and hearing you and hearing your concerns. Oh man, there's so much of what you said. I take some notes. I've been learning along with my colleagues here, so thank you. Our patients, like we said, they are, the majority of our patients are Hispanic, and we know that 37% of the Hispanic population right now in Texas has been affected by COVID. We also know right now in Texas, the majority of cases are in the 20 to 59-year-old age group, which matches exactly the age of the Texas workforce, right? And like we said, the Hispanic population may be at greater risk because they are the frontline face of the workforce. They are in the hospitals, and they are in some of the entry-level frontline jobs. They're the essential workers at the grocery stores. They're at the restaurants. They are RMAs or medical assistants providing that patient care. So their risk is greater too. And I wanted to piggyback on, I think it was Dr. Taylor that was saying that we really need to get away from the blame, because there's no blame here. These folks are out working every day and working hard. And we, if we're starting to put blame on any group of people, we don't need to be doing that. That's going to add to the mistrust. And so I was really glad that you brought that up, because these are hard working people. Most of them don't have insurance. So that's a real challenge. How do you access care if you don't have insurance? Our folks, like we talked about, we have I am muted, here we go. Multi-generational living environments that are going on in our culture. It's a very cultural specific thing. So when we're seeing one patient, we're seeing the whole family. And all of the family then becomes part of the visit because they're all affected. So there is a lot of barriers that are going on. And then, like we talked about the fear, I'm seeing this a lot in our patients. It's taken them a while to access care at Los Barrios. They understand that the fee is lower. But if you think about it from their perspective, you're coming in for testing, and what does that mean for you? Okay, if I say as a provider, you know what, we need to get you tested, and they say, what does that mean? They don't care about the swab in the nose. What they're saying is, so how long am I going to miss work? Do I have to stay out until I get test results back? How long is that going to take? And initially, it was taking a long time to get test results back. So we were knocking people out of the workforce because testing was not where it should have been, and they may have been home for 14 days or longer. So it was a big challenge, and people know that. So a lot of folks were resisting even being tested because they didn't want to be knocked out of the workforce. Dale and I were talking this morning about a patient that his wife was seeing and had multiple folks in the home all living together, and probably 3 or 4 of them were all positive. And so we were asking, why are people leaving the home, the others that are there? And they said, what would you do? We have to go to work. We're the only people that can bring income into the family right now. So it's very challenging when you talk about how do we box this in. We hear a lot about boxing in this illness. It is a multifactorial, it's a challenging situation right now. And there's a lot that needs to be done with it. But that implication of a positive result, that how long am I going to lose income? That's their greatest fear at that point. And so, when you look at that, how do we improve this in the Hispanic culture and in the culture of other minorities? And we have to provide culturally sensitive care, and we have to know our communities, and our communities have to trust us. And so that's been a great thing about Los Barrios is we're working, it's not just a standalone testing center. We're working with the patients because the patients know us, they trust us, they come in and they talk to us. Because the second part after testing, if you really want to mitigate the spread of this and start and try and bring it in a little bit and box it in as we talk about, is you've got to do contact tracing. How are you going to do contact tracing in a community that's fearful? We have folks that are limited by language barriers. We have folks that are limited by immigration status. They are terrified. When we tell them, you know what, we're going to be calling the health department and let's talk about who you have in contact with. And they say, what does that mean for me? How is that going to affect me? How is that going to affect my documentation status? How is that going to affect my family? And the fear is so high. And these are folks that have already had a lot of trauma in their background. So we have to really be that warm, just culturally appropriate center for them where we can walk with them through this, give them advice, let them know they're not alone. Hey, we are in here with you. We are going to walk through this together. We don't have to be afraid of the health department. We don't have to be afraid of doing contact tracing because we're in this with you now. And so there's this whole different way of providing care. And that's why I really am a firm believer in that primary care model where you have a primary care home that's trusting. And our medical home may not look like a lot of the other private medical homes, but we have that private, still that PCP, patient-centered medical home that's culturally appropriate for our Hispanic patients here in the Dallas area. And we're very happy to provide that because we have to deal with things all the time. We think, okay, what do we do as a community right now? Because our folks, and for that matter, my neighbors, my community, they are so confused because we're getting messages, okay, we're going to open up. We're going to open up, even though our testing rate is not flattening out, even though our positive case is not flattening, and our testing's still not where it should be. And we're getting this message, it's okay to open. And so even our employees here are asking me, is it okay? Can we go out? What does that mean? And so we have a big celebration coming up in the Hispanic community, which is Mother's Day. And in Mexico, Mother's Day is on May 10th. And this is a time where you better get together with your mom. And it's really interesting, even getting this message out to our employees, because they have told me, I'm feeling pressured. My mom says, you don't love me if you don't come see me. So we have to deal with that pressure of what do we do? How do we balance social distancing and masking, things that we need to do in a culturally appropriate way? How can we work with our community that you can honor your mother and you can respect your mother, but you may not have to get together with her for dinner if she's not in your household. And in fact, you may make mom sick or you may make grandma sick. So it's trying to learn teach those messages, learning them together because it's across the learning needs to go everywhere. Originally we were dealing in our organization with a lot of fear. Now I'm almost thinking there's really not quite enough fear because people are still wanting to get together and keep going and let's have our get-togethers. I'm going to go get my hair done or I'm going to do this. And no, we're saying stay home right now. Let's try and get on top of this together. And it's really going to take all of us in all of our outreaches out there. And again, Congressman Veasey, thank you for having us because we need to get this message out. It is not getting out there enough. So thank you.
Yeah, no, absolutely. And really just appreciate everybody coming on. Dr. Graham, Dr. Dale, Dr. Kincaid, Dr. Taylor, Dr. Davis, Lenore, really appreciate everything that you have had to share with everyone on healthcare, on staying safe, on hashtag staying at home. I think that is so crucial. I saw that someone on my Instagram, they were having a party to celebrate the life of someone that had passed away a year ago. And they had a backyard gathering and there were a lot of people gathered together. And I'm like, no, you can't do that right now. I understand it's a sad occasion, but you can't do that right now. We all need to do our part to hashtag stay at home to help flatten the curve as much as we can to alleviate the pressure on the healthcare system. And our doctors and nurses, our frontline workers in healthcare that are out there trying to help mitigate the effects of COVID-19 as best as possible. And I want to just, again, just thank all the panelists for being here today. I also want to ask everyone that's out there listening, watching on Facebook, that if you have any coronavirus information that you need or any help that you need on questions from the SBA or our Paycheck Protection Program, whatever it may happen to be, anything that's COVID related, that you can go to my website at vc.house.gov. And you can always email us, call the office. We are practicing social distancing and being safe in the two offices in Dallas and Tarrant County, my two district offices. And so we're asking people that, hey, leave a message and a caseworker will call you back so they can help you that way because the offices aren't open for for in-person visits, but we're trying to still serve the community as best possible. So with that, I want to thank all of our healthcare professionals for joining us. Dr. Taylor?
Okay, I wanted to ask Dr. Davis. So you mentioned people are hesitant to get tested, and rightfully. And so I'm asking you, is that legitimate though, right? Because if you test positive, what rights do you lose? What protections do you lose, especially in the early days, where if there's one case of COVID in Keller, everybody knows exactly who that person is, and they're completely shunned by society, and they are the ones who brought it into the whole community. So, I think I'm a physician, and I'm like, I don't know if I should get tested. I have been, but I understand the fear. And so when we reassure our patients and our community to get tested, can we honestly say they're safe if they get tested and they test positive? What happens? What is the answer you give to your patients?
That is a really challenging question. And so luckily, it's just like a lot of other, this is not just with this, I think about HIV too. It's like we need to test, we need to increase testing, and then the stigma needs to go away. Even with COVID, we need to work to get the stigma down. Dr. Major Kincaid, you were talking about, you just came out of quarantine and then you're saying it, and so I think people need to speak up too, and that's going to help. It's affected so many of us. So many of us are going to end up a year from now saying we were COVID positive at some point. And so I think we really need to speak up about it and take that stigma away so that it will help to lessen it. And then, when you're working with your patients and your communities, protect them. We need to protect them as much as we can as far as announcing things. And even in our organization, we're very protective about confidentiality. And then if patients are, especially employees, if they want to share it so they can help the rest of the organization realize, okay, this was my experience with it, and now I'm on the other side, and we can get through this together. And I think that's the message that we need to get out. But you're right, it's not easy.
And then, Congressman, I have one more question for you, or a statement. In Fort Worth, it has been very hard to get patients tested. It's been very hard to get people tested that may not be patients. Maybe that's changing, but I get a lot of calls from people in Fort Worth asking for direction on testing, and they can't get tested when they go to the hospital if they don't fit certain criteria. I know that you are not in charge of that, but I wanted to say that out loud so that you are aware, so that if there's something that you can say or do when you're in the rooms that you move in, maybe we can make that easier, so that, to Dr. Davis's point, if everybody gets tested, then it's not a stigma, right? Because there's so many positive people that it's just like having the flu.
Yeah, no, absolutely right. And right now over in Fort Worth, we are trying to work with a couple of the drugstore chains, Walgreens and CVS, to get more testing sites over here. FEMA still hasn't been over here. They've been concentrating over in Dallas because of the high rate of contraction and COVID over in Dallas. And so they haven't moved any of their testing sites over here. My understanding is that even though with that they only want people to come in that have symptoms at those FEMA sites. And so, yeah, getting everybody tested is a huge issue and huge concern. And we do need to have more people tested over here in Tarrant County. People forget that Tarrant County has about 2 million residents. So it's not quite as large as Dallas County, but it's really close. And so I think we do need to put extra emphasis here on people getting tested and getting services. Absolutely. So thank you. A very good point. And with that, we are going to sign off. But again, I just want to thank all of the doctors and healthcare professionals that were a part of the call today, and hope that we can do it again soon. Thank you. Everybody have a great afternoon.